appeal mostly to the women. Anyway, we hope today that this will go towards reconciling some of that. Dr. Michelle Fraser, whose achievement also out in the bulletin today, has of course been a long involvement with biotech companies, research institutes, universities, teaching and research hospitals. Now, in May of this year, she was appointed CEO of Reproductive Health Services. That company was successfully listed at the stock exchange last month. Her duties now include raising funds from the Commonwealth government, from state governments, and also in licensing and out-licensing activities and promotion of reproductive health sciences in the commercial and clinical network. I did see in the paper not long ago that there were something like 50 million people around the world with reproductive problems and fertility problems. So if they can knock a hole on that in the next year or two, that would be very good indeed. So I now ask Dr. Fraser to address you, and at the conclusion of the address, we have time for questions. Thank you.
Thank you for the kind invitation to come and present to your group today. I hope everyone can hear me, but please let me know if I need to speak more clearly or louder. Okay, see how we go. Right.
Down the bottom.
Down the bottom?
Minimise.
No. No mouse on the screen. We're off to a good start.
Well, that's
Reproductive Health Science is, as Ivan was saying, a publicly listed company. We listed on the Australian Stock Exchange through a reverse acquisition. Because I might actually raise that a little bit. Taller. It's got my heels on today. Thank you. So we listed on the Australian Stock Exchange in April this year through a reverse merger with a mining and energy company. So previously it was an energy company, then it became a mining company, and now it's a biotechnology company. Try explaining that to Americans, they just do not understand it. So basically, same risk profile, mining is out of flavour, biotechnology comes into flavour. Reproductive Health Science has got an interesting technology that sits within the IVF space, and I'll talk a little bit about why that space is interesting. And with Virtus Health listing last year in May, there was quite a bit of interest in the stock markets IVF technology. So it was a great window for RHS to become publicly listed, and so far so good. So the foundations of the company were really to try and improve IVF success rates, and the reason for that history is that we spun out of the University of Adelaide's Department of Obstetrics and Gynecology, and Professor Matthews, who is one of the guests here today, was involved in the start of this company, was a foundation investor in the company, and continues to be highly committed to the company. So we've got a very strong pedigree in IVF. Being publicly listed, I have to use the forward-looking statement slide, which I haven't had to do previously, so please don't go buying shares on the basis of what I say today. Make your own minds up. Why is IVF such an interesting market to be working in? If you look at the stats for Australian IVF, we do quite a few IVF cycles. You can see 66,000 people, couples per year will go into an IVF centre, have their eggs and sperm collected, and then try and fall pregnant from that. You may have the same patients come in more than one time in a year, so it's all counted in numbers of cycles. So 66,000 IVF cycles are started in Australia per year. Of that, 52,000 of them will create an embryo that can be used for IVF. but only 15,000 of them will actually lead to a pregnancy. So there's a huge 71% drop between having an embryo transferred and actually falling pregnant from that embryo. And I think if anyone in here knows anyone who's gone through IVF, this resonates very clearly. This is the failed IVF cycles that people go in for repeat treatments for. There's obviously a financial stress on the couple and also on the governments in Australia, in particular where we reimburse a lot of IVF costs. There's the emotional impact and trauma on the relationship of having to go back in and restart another IVF cycle. And there's also the trauma associated with a miscarriage, so the pregnancy may take at the start and then fail later down the track. So there's a lot of pressure on couples to conceive a pregnancy. The task ahead of RHS is to try and improve from that 71% attrition rate. It's been recognised, particularly in the past 18 months, that having the wrong amount of DNA in the embryo is the main cause for that IVF failure. So what we're looking at is an approach called pre-implantation genetic screening, or PGS, which you'll see mentioned in a few of my slides, which is basically counting the number of chromosomes in a cell in an embryo. Things that are associated with wrong numbers of chromosomes that people will recognise as Down syndrome, so extra copy of chromosome 21, that's one of very few viable wrong numbers of chromosomes that can lead to a person. Most of the time the embryo just won't survive, so it either will fail during culture before it's transferred, or it will not survive through implantation, so the patient won't fall pregnant, or it will fail later on down the track and lead to a miscarriage. So making sure that the embryos that are generated have got the right number of chromosomes is a way to try and improve the pool of embryos that you're selecting from for IVF treatment, and a way to significantly increase the success rate of IVF. And if you look at the number of embryos that have the wrong number of chromosomes in them, even patients who are 33 years of age or less, so the younger patients, have got a significant number of bad embryos. The older the patients get, the more abnormal embryos they produce, up to the point of women who are in their 40s having around 95% of their embryos having the wrong number of chromosomes. So if you had 10 embryos, you might have one that was good. They will look the same down a microscope, but they've got the wrong number of chromosomes, so they'll never lead to a pregnancy. So by getting rid of the ones that have got the wrong amount of DNA in them and just focusing on the ones that are good, that have got the right amount of DNA in it, it's been shown that you can increase the IVF success rates by 50% even in younger patients. So you're starting off with a much better quality material to try and conceive a pregnancy. The way that this works in practice is that when people go through IVF, they start with the egg and sperm collection, then they fertilise them, they let them grow in culture, and at day 3, when there's about 8 cells, they can take a cell out of that embryo and test it, and the rest of the embryo will go on to develop normally. They can do that same thing on day 5, where they can take 5 to 10 cells out of the material that goes on to form the placenta, so therefore not touching the developing baby, and they can test that and infer what's happening with the rest of the embryo. So you're sampling the embryo, make sure that it's healthy, and then progress with what's left over. Things that are driving the increased use of this genetic screening, at the moment it's being used in around 3% of IVF cycles globally, so it's at its very early stages of adoption. But things that are growing it are that even the younger women are seeing an improvement in their IVF success rates using this approach. There's a reduced risk of miscarriage, so there's not that trauma associated with losing a pregnancy down the track. It allows people, particularly in the US, to just transfer one embryo instead of transferring all of the embryos. So what happens in the US is you pay $15,000 for an IVF cycle, and what they'll do is they'll grow them all in culture, they'll look down the microscope, they'll say, okay, there's 5 that look like they're pretty good, they put all 5 in. If all 5 of them take, they'll have a voluntary reduction, so they'll get rid of a couple of them. But quite often in the US, there are twins or triplets born from IVF, and it's because they put so many embryos back in. The reason they do that is because they need those patients to fall pregnant. The health consequences of having twins or triplets or even more is that they're usually premature births that have a significant cost associated with care, so with with the preterm birds. So by being able to selectively choose one embryo that's got the right amount of DNA in it and transferring that one, they lead more often to a healthy outcome for the child, for the baby. So it's the way that the US is starting to progress. It's not just the embryos that are being used for IVF, it's also the embryos that are being put away for storage for later cycles. So people will come in and they'll have maybe 10 embryos to choose from. They'll use one of those, they may fall pregnant with that, they keep the other 9 in storage. By testing those embryos before they're put into storage, you're not going to be storing ones that are no good for future use. And there's a cost associated with storing those embryos. So you want to make sure that you minimise the amount of storage. And it's been shown that with older women, if you make sure that you're starting with a good quality embryo, they've got just as much chance of falling pregnant as a 26-year-old. So it's taking that whole maternal age factor out of the IVF success rate. So it's giving them just as much chance to fall pregnant, which obviously with an ageing population and an increased uptake of IVF by older women is a very important factor. So what makes RHS such an interesting company and the technology that we've developed? If you think about what we're starting with one cell. That's 6 picograms of DNA, which is nothing. So what you need to do is make lots of copies of as much of that DNA, as much of that genetic material as you possibly can. And that's done by a process called polymerase chain reaction, or PCR. So it's basically a chemical, artificial way of copying DNA the same way that your cell does in biology to grow. So we've developed a system to be able to do this here in Adelaide. Then you want to find out what's going on with that cell. There's no point making lots of copies of DNA without interrogating it in some way. And in the case of our technology, we're counting the number of chromosomes in that cell. And we do that using a method called microarray, which is basically a piece of glass that's got DNA printed onto it. And what you're doing is you're comparing how much material there is in an unknown test versus how much there is in a known reference, and making sure they've got the same amount as each other. So all of this technology has been developed here in Adelaide. It's been housed down at Theberton, down at the incubator that the South Australian Government has built. It came out of the University of Adelaide. The intellectual property is owned by the University of Adelaide and exclusively licensed to Reproductive Health Science. But this is a global product. This is something that we're not just going to launch in Adelaide, we're not just going to launch in Australia, we're launching globally. And we're taking on multi-billion-dollar companies with this technology. And what I think this demonstrates is that South Australia and Adelaide has got the potential to generate world-leading products for the biomedical space. And I don't think that we emphasise that enough as a city and as a state, that we can actually do this here. So what this has led to is a kit. So it's basically 2 boxes, one that's shipped cold and one that's shipped at room temperature. The one that's shipped cold has a whole bunch of tubes in it that are manufactured by our partner company, Kappa Biosystems, in Cape Town, in South Africa. So we have a bit of a connection. I went there earlier this year and it's a lovely place to visit, particularly Table Mountain. And at 4 o'clock in the afternoon, the clouds roll over the top of Table Mountain and form a tablecloth, and they start setting the table for supper. So whoever it is that's going over there, make sure that they go up to the top of Table Mountain. It's beautiful. So those parts of the kit are manufactured in Cape Town, and then we make the glass slide, which is the black box with the dots on it up the top. We manufacture that down in Theberton, and we'll continue to do so. We've got the capacity to be able to do that, to deliver products out globally. We may outgrow our space, hopefully, it's a nice problem to have, but there's no reason why we can't continue to do that here. This is a product that is deliberately designed to give a really simple answer to an IVF clinician and to a patient. So what our product does is it generates a graph, and if you can see the top graph here, what you've got is the ratio on the y-axis of how much test material there is compared to how much reference material there is. So you want everything to fall within those 2 red lines. And along the bottom is your chromosomes. So anything that falls outside of those lines has got a different amount of DNA in it than your reference material. So you can see the one in the green circle, that's chromosome 21, which says Down syndrome. So this is a result generated from a single cell from a Down syndrome patient. And this is how easy the results are, at least in my mind, to be able to understand, interpret and relay to the clinician, but also to the patient, to give them some idea of why their embryos are not suitable for IVF transfer, and to try and give them some closure. We are competing with companies that have market caps of 20 billion US, so we're taking on the big guns with this. But we think we've got some pretty interesting competitive advantages with our technology. The first one is that we've done an extensive amount of validation of our test performance to make sure that it works how we expect it to work before we use it clinically. Our competition hasn't done that. So we will be publishing that data and making sure that it's open to scrutiny to the clinicians and to the IVF clinics who are thinking about using this technology. We've got an easy-to-use, simple interpretation result, and that there's no complicated algorithms or anything that are needed to smooth the data or to try and help to interpret the data. It's that graph, and that's it. It's as simple as it comes. There's no complex genetic counselling, because if you've got the wrong numbers of chromosomes, it's not going to be any good to use. It's black and white. If it's got the right number, then it's fine. If it's got the wrong number, then don't use it. When you look at more complicated genetic tests, sometimes you can have small changes that may not be associated with any clinical pathology. Then you have to make a decision on whether to risk it and use that embryo still, or to discard it and stay on the safe side. The downfall of discarding it is that you might end up with patients with no embryos to transfer, and at the moment that's sitting at around 26% of IVF patients with the more complicated genetic testing. So we're hoping to reduce that. The ethical risk associated with complex genetic counselling can be that you might find something that the parents weren't anticipating you finding. Like maybe they'll find something like an adult onset disorder, Alzheimer's, something that the patient might not realise they were carrying. That then needs to be relayed back to the patients, who then need to go and have their own genetic screening done, and that may lead to consequences for their own health issues that they weren't anticipating. So there are incidental findings that can come with more complicated technologies. A good example of that was that there was a study done earlier this year that 12 people from Harvard students, healthy students with no family history of anything, came in and got their whole genome sequenced. And I don't know, some people may have heard of whole genome sequencing before. It's basically looking at all of your DNA to find out what's going to be wrong with you. Bit of a scary thought. Of those 12 people that came in that had no family history of anything, one of them came back with the BRCA1 mutation, which is breast cancer high-risk gene. She ended up having to go and have a double mastectomy and is now on surveillance. She didn't anticipate that outcome, neither did the people who were doing the study. So it just shows you that the more information you get, the more things you may uncover that you're not really prepared to deal with, and let alone trying to do that for an embryo. We're also being a developer of the technology ourselves and manufacturing some of the components ourselves. We've got a cost-competitive product. So we anticipate going out to the market with something that will compete with the products that are out there right now. And the IVF market itself, as I said, only 3% of them are using this type of testing at the moment. We anticipate that that will grow rapidly based on the randomised controlled trial data that's coming out recently. So we expect not just the IVF market to continue to grow at its around 10% per annum, but we expect that 3% use of PGS to increase quite significantly over the next 5 years. I think that's it. So that's the summary of the RHS story. Thank you.
We have time for 1 or 2 questions, so do we have any questions?
Oh, yeah, right.
Just start with
Peter.
Michelle, thank you very much. As a grandfather of 1.3 IVF children, can I say to you that not only is the subject of interest to all the people in the room today, but also very much something that the space you're working in is appreciated, I'm sure, by many people. my question is, and you touched on it briefly, but do you in fact see yourself getting involved in that, for want of a better term, genetic manipulation, so that some of these recurrent hereditary diseases or conditions can actually be moved out of the system by manoeuvring and playing around with the genes? I know there's a risk, but are you going to get involved in that space?
There's a big difference between targeted genetic screening, where you're looking for particular disorders that you want to try and eradicate from the population, and screening all of the genome, so looking for things like eye colour or intelligence markers, or the things that people talk about trying to improve in the population, and the scaremongering around genetic testing. Our initial product is specifically focused on trying to count the chromosomes for IVF. Our belief is that that sort of testing has to be done in patient populations where there is a familial history of something that needs to be eradicated. Use some more complicated technology for that. That's not what this initial product is designed for. Down the track, there is the possibility of product extension with our technology to include some of those disorders, and that's something that we're talking about with a number of potential collaborators. So yeah, it's something that down the track we may involve ourselves in, but right now this is very targeted, very specific, very simple to use, and deliberately trying to make the IVF clinics more accepting of genetic technologies and not getting them too involved in the very complicated counselling.
Thank you. Yeah.
Thank you so much. A couple of questions. The first is, if we take the, say from the chart you started at the beginning, 60,000 down to 11,
Yep.
if we take the next 100 babies born through IVF, what's the overall or the average cost of having one of those babies? That's the overall cost that includes all of the costs privately paid or government paid to actually achieve that baby. And second question is, if we still take those 100 babies and compare them to 100 naturally born babies, and if we look at defects on an average, what would be the difference of rate of defects in the 100 naturally born versus the 100 born by IVF?
So the cost for this type of technology, an IVF cycle in Australia is around $5,000. It's fairly heavily subsidised. Adding this sort of technology onto it, if you look at the IVF websites, it's around $3,500 out of pocket to patients. Now, I spoke to somebody, it's actually, because we're public now, I speak to a lot of brokers, and you wouldn't believe the number of brokers who've gone through IVF. I'm part counsellor with those meetings. But one of them had 3 cycles of IVF with this genetic testing, and he paid $13,000 per cycle. Of that, $4,000 was reimbursed. So there's a significant out-of-pocket expense to have an IVF baby, and there's an additional expense associated with this type of testing. But don't forget, 50% increase in IVF success rate. So you're offsetting the cost of the genetic testing by having a less number of cycles, and plus you're reducing the amount of trauma associated with those cycles. As far as numbers of abnormalities in the natural population versus this type of genetic screening, there is a reduction in miscarriage rate. There would be a reduction in the number of abnormalities. This is still very early stage. The numbers aren't there to support that. But certainly there are no reported false negatives, or that you don't deliberately transfer an embryo that's got the wrong number of chromosomes in it, so you would expect that to be much lower than in the natural population.
Thank you.
Steve, wants Michael to ask a question.
Thanks. I was just going to say, surely that's offset to some extent by, if you consider the cost of long or lifetime healthcare, it must be a huge cost. And I'm not trying to reduce this to dollars, but it's certainly an issue.
Well, certainly, when I was talking before about the US with the multiple pregnancy rates and the preterm births, there was a study done in California, and just by introducing this type of technology, they forecasted it saved the state $176 million in treatment for those preterm births.
I guess my point was, there's any substance seems to be money well spent.
Yeah.
Absolutely.
Time one. Yeah. You're out. Yeah.
Sorry, I've got a really simple question. If the rate of people that are infertile is say 10% in the general public, with your good work, that will increase in the future, won't it? Because what they're actually reproducing are people who can't reproduce. Is that correct or incorrect?
It depends on what's bringing them to the IVF clinic in the first place. If it's people of mature age, then no, they're not going to breed children who are not going to be able to reproduce, as long as they reproduce when they're less than 35 years old. You look at the ageing population that's going through IVF, more than 50% of Australian IVF patients are 35 years or older. So it's just time that's caused them to have problems with conceiving. If you're looking at patients who have more complicated genetic disorders that are preventing them from conceiving, then yes, this type of technology could potentially lead to them conceiving when they wouldn't have naturally, but the embryos are screened. So they would eradicate the genetic problem that those patients had when they came in by choosing an embryo that's healthy, that doesn't have the disorder that caused them to be infertile.
Thank you.
Yeah.
Thank you indeed, Michelle, for that talk today, and I trust that members, by their questions, have got some great thoughts as to what you have to say. I now ask you all to stand and thank you in the usual way.